Thank you. Can everyone hear me? I see so many familiar faces. Makes it so much better. So I'm here to talk about heart failure today, a problem that plagues so many. We're going to talk a little bit about what it is, types of heart failure, different treatment symptoms, and advanced therapies, monitoring, and something that I've found to be very important in heart failure care is palliative care and hospice as well. So we'll go over a little bit of everything. It is defined as the AHA as a chronic progressive condition in which the heart muscle is unable to pump enough blood through the heart to meet the body's needs for blood and oxygen, and it usually results in an enlarged heart. There are about 5.7 million people in the United States with heart failure. It accounts for close to 1 million admissions each year. And in 2009, 1 in 9 deaths included heart failure as a contributing cause. I mean, that's a very small percentage. About half of the people who develop heart failure actually will die within 5 years. So mortality is increasing steadily. And it costs about $30.7 billion each year in healthcare expenses, but that's also missed work, transportation, anything that goes along with it. This is just a little map to show you death rates of heart failure by age 35 and up. And you can kind of see the South is a little bit heavier with the number of patients, but still a problem across the entire United States. This graph, heart failure trajectory, I think many people may have seen, very commonly used. It shows just how heart failure progresses over time. You know, you have kind of a stable, once you're diagnosed, kind of a stable management, and then towards the end there's a lot of ups and downs, and that's kind of where the admissions are. And the last 6 months of a patient's life typically is where they spend the most money according to Medicare studies. So just kind of shows you the timeline. And I'm going to come back to this later just in talk of palliative care and when to start. So it's more common in patients who are 65 and older, in women, Black population, people who are overweight, and people who have had myocardial infarction. Some risk factors for developing heart failure: hypertension, coronary artery disease, diabetes, family history of cardiomyopathy, thyroid disorders, Graves, hyperthyroidism, treatments for cancer such as radiation and chemotherapy, those toxic meds, and sleep apnea. And unhealthy behaviors that lead to heart failure are smoking, tobacco, a diet that's high in fat, cholesterol, sodium, obesity, not getting enough activity or exercise, alcohol abuse, cocaine, and other illegal drug use, which could then lead to HIV and AIDS, and too much vitamin E. Causes of heart failure: again, heart attack, coronary artery disease, diabetes, high blood pressure, faulty valve, arrhythmia, cardiomyopathy, congenital heart defects, myocarditis, kidney damage or failure, and liver damage. And a lot of these things are going to be putting more stress on the heart, and over time it just, you know, can't hold up. It can't keep up with that kind of work, and it starts to give out. Kidney damage or failure is an issue because as the body retains more fluid, it puts more work on the heart as well. So in heart failure, patients can be classified in stages or classes, and it talks about whether the patient actually has risk factors but no symptoms, or if they have disease but they still have no symptoms, or if there's structural heart disease. And then the presence of advanced heart disease with heart failure and symptoms would be stage D. And then classification kind of goes based on how are they able to handle their ADLs, their limitation of physical activity, what they can do with or without symptoms. So we look at these when we're looking at patients according to their treatment and how to identify them. So some of the common symptoms of heart failure, I think the biggest one is usually shortness of breath and dyspnea on exertion, fatigue and weakness, edema or ascites. A lot of times they'll have an arrhythmia, so they'll have some kind of palpitations or irregular heartbeat. They're unable to exercise, but they just don't have that tolerance. A persistent cough or wheeze, especially while lying down, that orthopnea and paroxysmal nocturnal dyspnea is a common problem that they actually don't identify with. They think, I'm just restless, I can't sleep at night. So when you're talking to patients and you want to know, what are your symptoms, a lot of times they'll say shortness of breath, but ask them how they're sleeping. Can you lay down at night? How many pillows do you need to use? Because they don't register that as having a problem with congestion or heart failure. They just think they can't sleep. Nocturia increases more, of course, because gravity takes effect and all that fluid that was in their ankles is now making its way to the kidneys during the night. Weight gain, of course, is our biggest kind of indicator when the patients go home. We ask them to weigh themselves every day, and if they gain 2 or more pounds overnight or their weight's just kind of creeping up, they're supposed to call a cardiologist. Lack of appetite and nausea, you have decreased absorption, just the extra fluid, causes them just not to be hungry. Difficulty concentrating and decreased alertness. So those patients that kind of have mental status changes or just not following along as well, they could be an issue. And then chest pain because of all of that congestion. Also could be having heart. This is just a nice little table from the American Heart Association. I like it. It has little pictures. Sometimes they'll show patients, talks about the symptoms, why people experience it, and what they may experience. So again, the shortness of breath, coughing or wheezing, fluid buildup, fatigue, nausea, lack of appetite, confusion, impaired thinking, and a high heart rate. Okay. So there are several different kinds of heart failure. We have left-sided or left ventricular heart failure, which breaks down then into 2, diastolic and systolic. And we have right-sided heart failure. So left-sided or left ventricular heart failure is the most common cause of heart failure, and the fluid may be backing up into the lungs, causing the shortness of breath. Diastolic heart failure is now known as what's called HFpEF, heart failure with preserved ejection fraction. And you'll see that being documented more. And that is when you have an EF of greater than 50%. Now, the left ventricle loses ability to relax and can't fill properly during the resting periods. Systolic heart failure, or HFrEF, reduced ejection fraction, is less than 40%. And this is when the left ventricle loses ability to contract normally. So it can't push the blood out into circulation. Now, if you may have noticed, this is less than 40%. The diastolic is greater than 50%. What happens in between? And we do have many patients in between. 40 to 50% they call like the borderline. So it still could be considered diastolic, and it's kind of provider specific how they want to treat it, because each of these is treated a little bit differently as far as the medications. So here's a little picture of left-sided heart failure and some of the symptoms, because they present a little bit differently than right-sided. Again, we have the P&D because of elevated pulmonary pressure and the congestion, cough, crackles, wheezes, blood-tinged sputum, tachypnea, restlessness, confusion, orthopnea, exertional dyspnea, fatigue, cyanosis. So just some of the symptoms of left-sided. I love this picture. The different states of the heart, we have the top, which is normal, diastole, top left, bottom left, systole. And then you move over into systolic function and diastolic function. And you can see where there's difficulty with the ventricles filling and being able to get the blood out. I think it's a good diagram and nice to have. So right-sided or right ventricular heart failure is usually a result of left-sided heart failure or left systolic dysfunction. It can be caused as a result of right ventricular infarction, pulmonary hypertension, so those patients, with higher pulmonary pressures, severe tricuspid regurgitation, thyrotoxicosis, Paget's disease, which is a bone disease, pregnancy, severe chronic anemia, and of course, we also know it as cor pulmonale. the right side loses the power to pump, and the blood backs up, and that's when we get ascites, edema, and we get those symptoms of congestion in the rest of the body. Here's another diagram of right-sided failure. Again, fatigue, the ascites. That's when we get into more of the gastric issues, weight gain, anorexia, distended jugular veins. So when they're sitting up and you can see their jugular veins, real big concern, even when you lie them back, a concern. But and then the dependent edema. This is one tool I think is just a nice little acronym, FACES tool. Do you ever feel fatigue? Do you have altered activity? Do you feel any congestion in your chest? Do you ever get edema, or do you ever get short of breath? So just a way to remember some of the more common symptoms that patients experience and see, is this something that they're having an issue with? As far as heart failure medications, there are a number that are used to treat, and the treatment is constantly changing. In 2016, another medication was added, and they're finding it has good effects, and we'll talk a little bit about that. So we have ACE inhibitors, ARBs, ARNI, beta blockers, digoxin diuretics, aldosterone antagonists, hydralazine and nitrates, dobutamine, milrinone, and nitroglycerin. So ACE inhibitors, or ARB, work to help open the blood vessels and lower the blood pressure. And the medications listed up here are the acceptable medications to use in treatment of heart failure. Captopril, enalapril, lisinopril is what we commonly see, ramipril, quinapril, and benazepril, valsartan, candesartan, losartan, irbesartan, and telmisartan. The ARNI, which is an angiotensin receptor blocker neprilysin inhibitor, is new. It is known as Entresto. Sacubitril, valsartan. Sacubitril lowers blood pressure, and valsartan's an ARB. And it actually has been shown to reduce the rate of cardiovascular death and hospitalization related to heart failure. It did so well in its study that they actually stopped the study because of the effect that it was having. It is on formulary here now. It is starting to be used a little bit more often, so if you guys see it, you know a little bit about it. It should be started 36 hours after stopping an ACE or an ARB because it has an ARB in it, and we want to make sure the kidney function is good. If the patient has poor kidney function or hyperkalemia, those would be contraindications. Also, there are a few diabetic medications that are contraindicated with it, not commonly used. Kidney function and potassium should be checked within a week of starting Entresto, again, to see if it's having a negative effect. Hyperkalemia and increased serum creatinine, hypotension are kind of the big side effects. These are the doses, 24 and 26, 49 and 51, 97 and 103. They recommend starting at 49 to 51 twice a day, but a lot of the cardiologists, because they're starting new, we'll start lower with that. And then you can always titrate up. So here are some of the adverse side effects, and the majority, or the greatest effects were hypotension and hyperkalemia, but then some patients experience cough, dizziness, orthostasis falls, and angioedema, in very small percent. And if you want to know more about that, look out for one of Dr. Galen's talks. He speaks on Entresto. All right, beta blockers. They lower the heart rate by reducing the myocardial oxygen consumption. They help control blood pressure as well, and just to keep the heart pumping a little bit easier without a bigger demand of oxygen. Long-term studies have shown that they help heart failure from becoming worse. The accepted beta blockers are carvedilol, metoprolol, succinate, and bisoprolol. Metoprolol succinate and metoprolol tartrate are similar, except one is long-acting, one is short-acting. Tartrate's long-acting. In certain heart failure patients, succinate is preferred, and I'll get into that a little bit. So digoxin has shown to reduce the rate of hospitalization for heart failure, but it does not reduce mortality. It's usually used in patients with left ventricular systolic dysfunction, or HFrEF, who remain symptomatic while they're on the standard optimized therapy, or if they're in AFib. And of course, the concern with digoxin is we have to be careful with kidney function and checking DIG levels, because patients can easily become DIG toxic. So there are a number of diuretics used, most commonly furosemide, but we're starting to see a little bit more use of bumetanide or Bumex, torsemide, Demodex. Less likely hydrochlorothiazide, but it is there. And metolazone is many times used as an as-needed medication. It should be given 30 minutes before the loop diuretic to help kind of jumpstart it. But these are commonly what we're using. Ethacrynic acid, not as much, but I do see a couple patients that are on it because they're allergic to something like furosemide. Okay, aldosterone antagonists, such as spironolactone or eplerenone, Inspra, another name, prevent sodium and water retention. So they kind of help to get, and also spironolactone helps spare potassium, so in those patients who are constantly hypokalemic. And potassium levels should be checked because they're leaving it in the body. Hydralazine and nitrates are becoming more popularly used, I think, with treatment of especially the patients in HFrEF. It's an arterial dilator, and nitrates are a venous dilator. The combination is reasonable for patients who have current or prior symptoms of heart failure, and they can't be on an ACE or an ARB, whether it's drug intolerance, renal insufficiency, or hyperkalemia. And they can be added to ACE inhibitors and beta blockers when afterload reduction is needed or pulmonary hypertension is a problem. Many of our patients do have that comorbidity of pulmonary hypertension. And dobutamine and milrinone are, I think, more commonly used in the ICU to enhance contractility for especially patients with acute hypotensive heart failure or shock. It shouldn't be used long-term, but intermittently it can be. And if it is a chronic infusion, usually it's reserved for patients with palliative care or just kind of symptom management. Again, milrinone enhances contractility for low output heart failure and pulmonary hypertension. It helps with when being used with a chronic oral beta blocker therapy. Again, not for chronic or long-standing infusions. Nitroglycerin at low doses can be a venodilator, and at higher doses an arterial dilator. It helps, of course, with blood pressure control and management, and helps with alleviate any kind of pulmonary congestion. Many times we'll see these with our STEMI patients and other MIs. Overall, diuretics are needed in most patient management for fluid retention. Again, we have to remember to look at the kidney function. Digoxin is reserved for patients with signs and symptoms of heart failure. Aldosterone antagonists improve survival and prevent hospitalization. And hydralazine plus a nitrate can be added to ACE and beta blocker for additional symptomatic benefits. For heart failure with reduced ejection fraction, again, that's the EF of less than 40%, patients should receive at least one of the ACE inhibitors as long as they can tolerate, and one of the approved beta blockers. So that would be the metoprolol succinate over the metoprolol tartrate, carvedilol, or bisoprolol. And it's important, if you're reading the charts as you see it, it needs to be documented why they're not on it. And you should know if they're, why isn't this patient on it? This is the guideline-driven medical therapy. For HFpEF, or the preserved ejection fraction, there's really little research on what medications are great. So the important thing is close follow-up and continuous education and communication with patients so they, we can manage their symptoms a little bit better before they get into trouble. Other medical therapies, of course, if they have coronary artery disease, aspirin and a statin to keep their cholesterol low, warfarin for patients who have higher CHA2DS2-VASc scores, AFib, aflutter, any kind of embolic event, aneurysm, thrombi. And then, of course, treating AFib, so rate control. A lot of times if patients are constantly having difficulty with rate control, they're going fast, it could lead to an exacerbation of heart failure, just as an exacerbation of heart failure could lead to AFib. So it's kind of like which came first, the chicken or the egg. Treating sleep apnea, anemia, obesity, thyroid disease to help kind of keep away from those exacerbations. So here at Danbury, we do the American Heart Association Get With the Guidelines for heart failure. We're looking to get that kind of notoriety. And what we're looking at right now with patients before they leave is, do we have the achievement and quality measures? And these include, again, making sure that the patient who has a reduced ejection fraction goes home on an ACE or an ARB, the approved beta blocker, and that the LV function is documented, whether, it was an echo that was done a couple of weeks ago or a catheterization or stress test, but the ejection fraction should be documented. And a follow-up appointment needs to be scheduled and documented before discharge. So if you guys are seeing that patients are leaving, they don't have an appointment, something to address. Sheila is typically following the patients with heart failure, so certainly you can talk to her, Chris, or Sarah, any of the navigators. But we find there's better compliance when patients are leaving with an appointment and they're seen within, we try to actually get them in within 5 days, and the outcomes are better for them. For heart failure patients here at Danbury, the average day for them to get readmitted is day 10. So if we're seeing them on day 5 and coming up with a plan, to keep them out, it's more helpful. The quality measures include, and they don't have to be done, but it does help. Aldosterone antagonists at discharge, anticoagulation for AFib reflutter, hydralazine, DVT prophylaxis, a discussion of chronic resynchronization therapy, whether it's a defibrillator or pacemaker, is either placed or prescribed at the time of discharge, defibrillator counseling, flu vaccine during flu season, pneumococcal vaccine, and then again, the follow-up within 7 days or less. So outpatient management, this is kind of where you guys probably aren't too familiar with what goes on once they leave the hospital. It's kind of like goodbye, good luck. When they get out of the hospital, there are several care coordinators. So I follow all the patients that are at Western Connecticut Cardiology. There are care coordinators in primary care offices following other patients as well. We make it a priority to contact them within 48 hours, at least 1 to 2 phone calls to do medication reconciliation, make sure they know about their appointment, address any issues or concerns, assess their med compliance, and identify any barriers and kind of coordinate any services. Did they refuse visiting nurse and now all of a sudden they want them there? We try to set that up. We also provide IV Lasix in our office. Many of the facilities, hospices, also do IV Lasix. So something to think about, when you have a patient, if you're discharging them or if you know what's going on, and they start to mention things about barriers, oh, I don't really have rides, or I don't have, whatever it may be. These are all really good points to bring up to Sheila or one of the case managers to address it. We do it outpatient, but it is incredibly helpful if it's done before they even leave the hospital, kind of setting up. I think a lot of the heart failure readmissions and the quality of care could improve with our discharge process to help identify concerns before the patient actually leaves the building so that they can be addressed. We also talk about goals of care, what they want, what they're, and it may not be medical, it may just be something that they want to do. I want to be able to walk outside or garden. So heart failure management, patient education. We talk about the sodium diet. Anywhere between 1,500 milligrams to 2,000 milligrams is recommended. We do a little education on reading labels, what foods are good, bad, ugly. Monitoring weights every day. We try to get them on a routine of calling to report changes or any kind of symptoms. It becomes really overwhelming for patients when you're doing education. I can imagine in the hospital it's more challenging because they're not in their normal state, they're feeling ill, they're not in their environment, so they don't retain as much. The biggest thing I tell them is just to make sure if you have any baseline changes, if there's anything that's keeping you from doing your normal activities, you call to report it. We have the monitoring blood pressure, reviewing medications, smoking cessation's big, light aerobic exercise, knowing who to call. We give them a dry weight sometimes it's not that simple, and then also follow-up visits. Cardiac rehab, we're starting to refer more patients, not just for after MI, but for patients with heart failure. They do have a program. It improves their symptoms and exercise tolerance, and helps with weight loss, actually, and also provides additional support and education for the patients. So CardioMEMS, you may or may not have heard it, is a new device that we're implanting here at the hospital. We've done 2 already. It's inserted via a cardiac catheterization, right heart cath, and it sits in the pulmonary artery, typically the left, although it can be put in the right, to measure the pressure and determine fluid volume. In order to get one, patients require admission for heart failure in the past 12 months. They have to be documented class 3, but typically if they're admitted with symptoms, they will be class 3. And they need to be able to take clopidogrel for 30 days and aspirin for life. These little devices, and actually I think I have a picture. So it's a tiny device. This is a dime. It's the size of a dime. It endothelializes in the artery. It kind of just sits there. And we're able to transmit the signal. Patients are actually able to lay on a pillow at home that they're given. They transmit a signal to this ginormous machine, which then uploads to a website. And every day I go on and I look to see what their pressures are. We look at the diastolic pulmonary artery pressure. And when they have the cardiac catheterization, they actually measure their volume status. So they see at the time of the cath, were they a little bit wet, dry, or was it a good measurement? And the pressures will typically change weeks before patients are symptomatic. So before they're saying my weight's going up, or I have swelling in my legs, or I'm short of breath, we can notice the change. And it's not something that we have to jump on right away. We can kind of look at the trend and see, where are these pressures going? And we can actually make those changes over the phone. So the patients like it because they don't actually have to come into the office. We're able to monitor remotely, and it's reduced in this Champion study, which was the study for CardioMEMS. It showed a 33% reduction in all heart failure patients in readmissions. It's not specific to reduced ejection fraction or preserved ejection fraction, and it actually, that 33% reduction includes both groups. At Danbury, the majority of our patients that come back are actually diastolic heart failure. The other way we monitor is telehealth. The visiting nurses will bring, while they're on service, a monitor to the patient, which does weight, vital signs, checks their blood pressure, pulse ox, heart rate, and transmits the results real time so that we can see what are the changes. It's been helpful. We've had a few kinks, but the patients seem to like it, and also gets them on a routine of checking their weight every day, checking their vital signs, and knowing, when there's an issue. The I Get Better study was a study that Dr. Owana Penshu, one of our fellows, did, which sent home a patient an iPad and a blood pressure cuff and a scale, and the results were transmitted to her, and we were trying to see the reduction in heart failure. We had a small population that was put on the I Get Better study, but the results were pretty good. So many of our patients are, they come in with an acute exacerbation, we tune them up, send them out, but there's still the population of patients with advanced heart failure. And that's those patients with persistent symptoms, despite being on the appropriate therapies, it's no longer working. And we call that class 3 or 4 in stage D. So what do? We have the chronic resynchronization therapy, which improves the heart's efficiency and increases blood flow, and we do that through pacemaker defibrillator. These are the guidelines for that they need to have in order to receive one. So the class 3 or 4, symptomatic despite medications, again, advanced heart failure, an EF of less than or equal to 35%, wide QRS, and evidence of dysynchrony. Defibrillator therapy, approximately 50% of patients with heart failure die suddenly. So if we can get defibrillators into these patients sooner, we may be able to improve those numbers. especially with their antiarrhythmia. If they've survived cardiac arrest, had VTAC, induced or sustained, an EF of, again, less than 35%, or dilated cardiomyopathy, they would meet criteria for a defibrillator. There is a pacemaker, tiny, come a long way. LVADs, we are not an LVAD center. We usually send our patients off to Yale. But again, for patients with heart failure, they can either be used for bridge to transplantation or a destination therapy, kind of palliative for the patient. So hopefully in the near future, we'll be seeing more of those here. And that's what an LVAD looks like. And then cardiac transplantation, so a transplant, usually for healthy patients other than their heart failure, with a severely impaired function, and they're on optimal medical therapy. If they have chronic medical comorbidities, hypertension, active infection, psychosocial contraindications, or noncompliance, they do not meet criteria. Survival after cardiac transplantation is about 85% at 1 year, and it's about a 13-year life expectancy. So palliative care, we talked about kind of the advanced therapies. Palliative care would be another thing to consider for those patients with advanced heart failure, although it should be considered much earlier. Patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs to facilitate patient autonomy and access to information and choice. Care is provided and services are coordinated by an interdisciplinary team, which includes patients, families, doctors, nurses, aides, healthcare providers of all different kinds. And there are services available inpatient and outpatient. I don't know if you guys are aware of that. We do have our palliative care team, but we also have it in the outpatient setting as well. We're trying to get them involved earlier. It's more difficult to talk to a patient about palliative care while they're here in the hospital, not feeling well. They're thinking you're talking about end-of-life care, which isn't what it is. And would be better off planning for it in the outpatient setting, so preparing and talking about patient goals. So again, the trajectory at the end, the last 6 months is usually when they spend the most money. If we were able to get palliative care involved sooner to address concerns and discuss with patient possible outcomes, we maybe have a better outcome and a better trajectory. It is appropriate at any age, any stage, and can be provided along with curative treatment. It is not end-of-life care. That's the biggest thing to take home. A lot of providers, old school not, think when you say palliative care, that's the end, we're not doing anything more. It's more about coming up with a care plan, goals for the patient, and addressing symptoms and issues. So it should be used concurrently with the treatment plan. Hospice focuses on caring, not curing, and most cases are provided in the patient's home. It's, again, a team-oriented approach, and this is end-of-life care. It's also nice because it supports the patient's family and loved ones as well. We do have centers. It can be provided in hospitals, facilities, and it provides a number of services. Our local regional hospice actually has a program called the Choices Program, which allows patients who meet criteria for hospice but just aren't ready to stop treatment to join their program. They get all the hospice services. They can still see all of their providers, receive all of their treatment, and it helps to bridge them to hospice when they're ready. Referral to hospice is considered when a physician believes the patient's life expectancy is less than 6 months, and the patient is usually end-stage heart failure with an EF of less than 20%. And these are my, oh no. Yes. The light of my life, Norman Oliver. I figured I'd end with that. Does anyone have any questions? Curious? So promote palliative care, please.